Miao Zhang is a fifth-year PhD candidate at the NYU Chinara Lab and has already, I think, established herself as a really prolific researcher with some top publications in AAAI, which I heard is a top publication venue, as Aaron Coletta said, and as well as PNAS and additional other publications. So already starting extremely strong. And I also remind anyone who's on the job market that Cades is hiring a professor of practice. Without further ado, I'm really excited to welcome Miao Zhang here to talk about big data and public health decision making.
Thank you so much for a kind introduction. Hi, everyone. I'm excited to be here to introduce one work from our lab with a theme in trustworthy or responsible AI usage in public health. Um, yeah, so I would like to share some concerns about the using big data with AI tools for public health decision making, but without considering too much of the domain context or knowledge. So to start with, I believe nowadays most people have been using Google Maps on a daily basis. This platform has functions beyond navigation, but it collects and provides visual information for the environment we are living in very thoroughly and up to date. Um, it's also easy to access the data. You just register a Google Map account, specify a location you're interested in, then you will get an image for basically any corner of the world. So with that powerful tool and like a data-rich platform, public health researchers have wonders. Can we use AI and this data to read our street and predict our health? To achieve that goal, the first step is to extract useful information or like labels from the unstructured and crowdsourced street view images. And convolutional neural network is commonly used, a category of deep learning networks. Of course, more advanced models can be used, like vision language models, LLMs. So people have extracted information like different land use types, like the areas for buildings, for walking infrastructures, parks, or agricultural land for rural areas. Also, people can measure the urban mobility patterns, like in the different times of a day. And additionally, the urban perception, like very subjective perception from people, like whether people feel safe about their environment or unsafe and depressing. So we call these factors extracted from images as built environment factors. Built environment factors have been shown to associate with health. A given example, like researchers found neighborhoods with more tree and sidewalk presence, like the two images on the left, are associated with lower cardiovascular events, physical and mental distress risks. This is compared to like neighborhoods with less green spaces and less walkability facilities. And these images are from New York City. So it's just a table results for that conclusion. I would like to mention this study because it's performed on 500 cities across the United States. So a pretty large scale and based on a lot of like data. And they examined the street greenness and crosswalk of built environment factors and proven to connect to obesity, diabetes, and physical distress. So with all those like seemingly very promising connections and insights from like the built environment factors of our living environment or neighborhoods to the local health outcomes, we wonder if that's the whole story. Like, can we solely rely on the information we get from images or big data to predict our health? Are we missing any intermediate mechanism or variables that can like moderate or mediate these relationships? So that like motivates our study. To investigate that issue, I will build this model by introducing an additional variable, a potential mediator, the physical activity between like the built environment and the health. So this is where I would say the domain context or domain knowledge might come in, because initially we just searched public health literature, and we are aware of that people's movement or activity level has shown to be beneficial for health improvement. And also, intuitively, more crosswalk and sidewalk infrastructures will encourage people to move more, so that this variable physical activity is very likely to delivers the effect from environment to health. That's why we build this model and do the mediation analysis based on the 3 sets of regression analysis, from exposure to outcome, from exposure to mediator, and from mediator to outcome. So for the data sourcing, we collected images from Google Street View platform, in total 2.2 million images, covering every single street across New York City. And for the data of health outcomes and this activity level, they are collected from NYC Open Data. It's a very useful platform. Yeah, and we also control for socioeconomic variables in the analysis. So the mediation analysis results are like in this table. Though there are many numbers, I think there are 2 main takeaways from the results. First, the column of mediation effect shows they're really statistically significant and of large magnitude. They're even larger than the total effect from environment to health. So I would say here, crosswalk and sidewalks influence on health is largely delivered by an individual level of activity, like whether people are willing to walk more or not. That's what really matters. And for the sidewalks predictor, the total effect of sidewalk here on health is even not significant. That shows like the built environment effect on health is entirely mediated by this activity variable. So far, we have some insights that there's really a middle pathway that plays a big and significant role in influencing people's health. So we already observed a strongest effect from activity to the health outcomes. And the next question is, can we use this insights or conclusion to instruct policymakers like New York City government to how to improve health, since that's the ultimate goal of performing research in connecting environment to health outcomes. So we, according to that, we performed intervention experiments, like by either intervening on the building infrastructure, building more crosswalk and sidewalk, or intervening on the people's activity level. So we found that 1 unit intervention on physical activity, like you can use free class, education, or events to encourage people to move more, that would result in around 4 times bigger decrease on obesity and 17 times bigger decrease on diabetes compared to the same unit intervention on building more crosswalks. So that gives interesting insights that when we build the public health models to indicate health improvement, ignoring important mediators or any indirect variables that may play an important role in this context can cause misestimated intervention effect or lead us to less effective and more costly approaches. But there actually are better methods there. So far we have seen risk of like less comprehensive model constructor and why that could be an issue. And I just want to take a step back to briefly mention another risk of extracting information from big data. Like we have very powerful AI tools to just kind of gather the labels and very broad insights from data around the world. So we need to be mindful that models are not 100% accurate. Like if we are wrong from the first step, like some measurement errors, then that will cause a big influence on the analysis afterwards. For example, like we use the deep neural networks to recognize sidewalk, but there could be false positive cases. Like the model will recognize the emergency lane on the highway as a sidewalk, or just parking lot as a sidewalk, and with very high confidence scores. Or there could be false negative labels, like if the sidewalk is covered by tree shades or there are vehicles parking ahead of it, the model will simply cannot recognize that. So to build more robust and generalizable AI models in difficult scenarios is also one important step to keep in mind. So as a summary, considering the two risks covered, I would conclude like big data is not enough. Like we need domain knowledge from either public health side or computer science side to make this meaningful. With domain knowledge, we can do more validated models and measurements, and therefore to understand the built environment's effects with a more fine-grained mechanisms. And that will eventually, hopefully, to lead us to more actionable and effective health interventions that will really benefit people. So yeah, that would conclude the content, and I would love to keep discussing offline. Thank you.